Good afternoon. Welcome to the Mid-Atlantic Patient Support Group meeting, FSH Society. My name is Carla Grossman, if you're just tuning in. I'm an adult neurologist, and right now I am fortunate and very privileged to be the Wellstone Fellow in Clinical Research in Muscular Dystrophy here at Kennedy Krieger Institute and the Johns Hopkins School of Medicine right here in Baltimore. And I've been participating in many clinical trials related to muscular dystrophy under the expert guidance of Dr. Catherine Wagner. And in addition, I'm on the faculty at UCSD in San Diego, where I will be returning after the fellowship. So today I'd like to talk to you about bone health in FSHD. So this group here, I know you know a lot about FSHD already. I'll just go over some very brief points. We know it's inherited. There's two different types. The majority of FSHD is due to mutation on chromosome 4, and there's a very small percentage on a different chromosome, chromosome 18, that's FSHD2. We know it's a disease of weakness in a very specific distribution, and that's how it got its name, FSH, starting with the face. Scapular is the S, H humeral over the upper arm, and then also involves abdominal muscles and the distal leg. This weakness is very slowly progressive, and it's often asymmetric, meaning one side is more affected than the other. The loss of strength results in decreased muscle mass. So if I'm talking about a muscle disease today, why am I concerned about bone health? So what we do know is as muscle mass decreases, bone density, that is the strength of bone, decreases. And with increasing weakness, there's an increased risk of falling. So these two factors together, decreased bone density and increased risk of falling, puts an increased risk of having a fracture, resulting in pain, loss of mobility, and declining quality of life. And that's why we're concerned about bone health. So in order to understand the relevance of bone health and FSHD, I'd like to review some basics in bone physiology, talk about bone health in the general population as well as in other neuromuscular conditions, talk about how we measure bone health, as well as what are the risk factors, how can we prevent, and what is the treatment for poor bone health. And I'll also talk briefly about our current study in bone health here. So what is the function of bone? It's primarily structural. The hard skeleton protects our organs from injury, and the bone's attached to ligaments and muscles, allowing us to move, call that locomotion. It's also a metabolic reservoir for minerals such as calcium. Bone is alive. It's composed of collagen and minerals. The collagen is a protein that provides a very flexible framework, and these little threads of collagen are twisted together into fibrils, and then they are arranged in layers with calcium and phosphate, which are minerals, embedded in the bone so it can withstand stress. Tornado warning?
All right, you're good.
So going on with more about bone physiology. In our human skeleton, we have two different types of bone. The outer, by the way, this is a picture of our hip, that's the femoral neck. We have an outer cortical bone, which is very dense and compact, resistant to bending. And then inside, that's the other little insert, you can see a honeycomb structure. That's the trabecular bone. And this part of the bone is much more elastic. And during puberty, it increases in density. As we get older, this area becomes much less dense. Bone growth is always changing, it's dynamic. What that means is bone is constantly being renewed. Parts of bone are removed when it's damaged or when it gets older, and it's replaced with new formation. And this process of formation and removal of bone, which we call resorption, is called bone remodeling. And there's special cells that are involved with remodeling. The top ones are osteoblasts, and they're responsible for laying down bone for formation. Below are the osteoclasts that eat up bone. And we actually need osteoclasts to resorb old or damaged bones. So we call that resorption when bone is removed. That's important when we start talking about therapies. So here's a cartoon just showing how the red osteoclast is chewing up the bone, the probably old or damaged bone, and then the green osteoblasts are coming in and laying down new bone. It's a constant process that varies with age. In childhood, formation outpaces resorption, so we lay down a lot of bone. As a young adult, that's when our bones are absolutely the strongest. But as we get into our 30s, this kind of plateaus. Formation couples with resorption, and as we get older, we start to have a rapid loss of bone because resorption, that means removal of bone, exceeds formation, resulting in bone loss. So what determines how much bone mass we have? Probably the most important is our genes, what our genetic predisposition is. There's also other factors. There's endocrine factors related to hormones. I'll talk a bit about that, as well as our lifestyle. So hormones are chemicals that are released from glands that regulate behavior, growth, reproduction. Estrogen is a hormone that's very protective for bone, and it prevents the formation of those osteoclasts that resorb. So when a woman hits menopause, there's a sudden decline in estrogen, and this leads to the accelerated bone loss because there's less protection, and this results in bone loss in postmenopausal women. Testosterone, male hormone, is also protective. It inhibits bone resorption and helps maintain bone mass. Low levels of testosterone are associated with accelerated bone turnover and an increased fracture risk. So other hormones that are involved with bone remodeling include these two hormones that are released from glands in the neck. The parathyroid gland is the pointer showing you it's behind the thyroid. It's released when calcium is low, and it stimulates bone formation. Calcitonin, which is produced by the thyroid, also stimulates bone formation, and this is released when calcium is high. And it also reduces the activity of those osteoclasts. Now, both of these hormones have been synthesized and are FDA approved for treatment of osteoporosis, but they're not first-line therapy. So other factors that affect our bone mass: diet, nutrition. Calcium and vitamin D are absolutely essential. We need vitamin D so that we can absorb calcium, because calcium cannot be absorbed from our small intestine if we don't have vitamin D. You may have heard of the condition called rickets. This is severe deficiency of vitamin D in children, and it results in softening of the bones or osteomalacia. We can check our vitamin D levels, and if it's low, it can be replenished. Are you aware of some sources of vitamin D? Not sun. We're not seeing any sun today. So what other sources of sun is not available? Okay, here, as far as how much sun is good. So skin exposure to ultraviolet radiation provides vitamin D, but it requires that you don't have any sunblock on or you're not wearing clothing. It really has to be direct exposure to the skin. So too much is probably not a good thing. From this paper, An individual in a bathing suit generates 10 to 25,000 international units of vitamin D after a minimal dose, which is the safest amount of radiation to produce redness in the skin, an erythemal dose. So my interpretation of this is don't get red, so maybe 15, 20 minutes when it's sunny out. But of course, you have to use caution. Other sources of vitamin D besides the sun. Food sources, different types of fish, salmon, tuna, herring, eggs. There are a lot of products that are fortified with vitamin D if you look on the nutrition labels, especially the milk alternatives, orange juice, cereals, and then you can actually buy vitamin D as a supplement. Calcium is also required for bone maintenance, and our needs for calcium change throughout the life cycle with peak needs in adolescence and times of rapid growth. Sources of calcium primarily are from milk products, but many people are intolerant to milk or lactose, so there are milk alternatives as well as fortified products with calcium. Tums are a great source of calcium as well. And another source that a lot of people overlook, sources of calcium, include these green leafy vegetables, as well as almonds and other nuts, Brazil nuts, pumpkin seeds, avocados. So there are a lot of dietary sources, and dietary sources are probably the best source rather than taking supplements. There are recommendations for what we call RDAs, recommended dietary allowances. If you can Google, you can see that in adolescents, 14 to 18 years old is when we have the highest RDA. So other determinants of bone mass, lifestyle. Smoking is actually bad for your bones. He believes that it's anti-estrogenic. Alcohol in excess is bad for your bones, and it's not clear if it's actually toxic or is it because it may affect your balance. So the recommendation is less than 3 alcoholic drinks a day. Exercise. So exercise is actually fabulous for the bones. It promotes bone formation. Weight-bearing activities and mechanical stress, just moving the bones around, promotes increased bone mineral density. High impact is better than low impact, but any exercise is better than none, because truly, use it or lose it, inactivity such as prolonged bed rest or being immobilized causes severe bone loss, and that's because with immobilization, the osteoblasts, the cells that make bone, are inhibited, and it accelerates the osteoclast resorption. So mobility is important, and so is gravity. Mechanical stress and lack of gravity affect muscle and bone, and we've learned a lot from the space program. We've learned that astronauts lose a tremendous amount of muscle and bone when they're in space. I thought there's an interesting study. They looked at 13 astronauts on the International Space Station for about 4 to 6 months, and they had a reduction in their hip bone strength in this period of time, 4 to 6 months, comparable to a lifetime as seen in Caucasian females. So gravity is very important. So who is likely to have a knee fracture? What are the risk factors? Age is definitely a factor, and after age 65 is pretty much even for men and women. But around, say, 45 to 55, postmenopausal women, they have a higher risk than men at that time due to the sharp decline in estrogen with menopause. Ethnicity matters. Being Caucasian and Asian puts you at higher risk. Having a family history of fracture, having a previous fracture. Believe it or not, low body weight, weighing less than 127 pounds, puts you at a higher risk for fracture. As I mentioned, smoking and alcohol. And certain drugs can affect our bones, can cause demineralization. Steroids, corticosteroids can have an effect, as well as some seizure medications. This is a graph looking at fractures in women, the incidence of osteoporotic fractures in women. I don't have a pointer, but you can see until about age 45, 49, it's pretty much flat line, except for the wrist. When you fall and you put your hand out. Starting around menopause, you can see the incline, and then 70, 74, hip fractures really increase, along with vertebral fractures. Wrist fractures kind of bottom out, or level up, become much more level. In comparison to men and their osteoporotic fractures, fractures, they lag about 10 years behind as far as when their fracture incidence increases. But they also have a very significant amount of hip and vertebral fractures from osteoporosis. So how do we measure bone health? Primarily through imaging, meaning x-rays, as well as blood testing with bone biomarkers. Bone biomarkers are used clinically to look at bone turnover. That means remodeling, to see how fast our bone is being resorbed. We also can use bone biomarkers in research to look at outcomes. However, the best predictor for fracture would be to look at bone mineral density. And the best test for looking at bone mineral density is the DEXA scan. The bone mineral density test will determine whether or not you have osteoporosis. So DEXA stands for Dual Energy X-ray Absorptiometry. And it's an imaging technique, as I said, it's a technique of choice. It's very easy. Some of you have had it. Minimal radiation, and you lay on a table. It's not uncomfortable. 2 X-ray beams are aimed at your bones. The soft tissue is removed, and the bone mineral density is determined. You can also get lean body mass from the DEXA scan. And unfortunately, as we get older, our lean body mass decreases, and we have an increase in fat. There is some suggestive evidence that higher lean body mass is positively correlated with bone mass, meaning that if you have more lean body mass, your bones are going to be stronger, and you're going to have a less risk for fracture. Okay, so you have a DEXA scan, and you're going to get a result. It's either going to be normal, osteopenia, or osteoporosis. And the way that these 3 different diagnoses are decided is based on scores called either T-scores or Z-scores. The Z-score, so you might see the Z-score at the left hip is -3.8. So the T-score is comparing the patient who's having the study compared to young adults at their time of peak bone mass. So this is usually over age 50. The Z-scores are for people below age 50, comparing their bone mineral density to persons of the same age. Talk a little bit more about that. Just to give you definitions. Osteoporosis, osteopenia, what's the difference? So osteo is the Greek word for bone, penia, lack of or deficiency, porosis or porous means something filled with holes. So osteoporosis is bone filled with holes. So what is osteoporosis? That is your diagnosis. It means that you've lost mineral and structural integrity in your bone. And the reason we care about this is because of a higher risk of fractures, but there actually is treatment for osteoporosis. So if we were to look inside the bone, we talked about the trabecular bone, that honeycomb structure. You can see the normal bone matrix. Next to it, osteoporotic bone. You can see it's very porous. There's very big holes. And it's much more fragile and much more prone to fracture. The World Health Organization has set criteria for deciding what is osteoporosis and what is osteopenia. So we use the T-scores and the Z-scores. In the very middle of the graph is the average. If we would go to the left, 2.5 standard deviations, that is, if you would fall there, that's osteoporosis. If you fall between 1 and 2.5 standard deviations, it's osteopenia. Another way to make the diagnosis, besides with the DEXA scan, is if you have a fragility fracture, meaning minimal trauma, you just sit down and you break a bone, or something drops on your foot and you break a bone, or you have a spine x-ray and you see a vertebral compression fracture, you have osteoporosis, you have a fragility fracture, and you should probably consider treatment for osteoporosis. There's one other tool I wanted to mention. It's called the FRAX. It's a fracture risk assessment tool, again designed by the WHO, which can calculate a 10-year probability of having a fracture based on bone mineral density and looking at all of the risk factors that I've mentioned. This tool is country specific, so I pulled up the United States, and you can see the things that they're interested in: sex, weight, previous fracture, parent fracture, smoking, alcohol, and then bone mineral density at the hip, the femoral neck. If all those things are placed, you can get your 10-year probability of having a fracture in 10 years. So how can we reduce the risk of fracture? fractures. Talked a little bit about lifestyle and nutrition. Calcium and vitamin D are so important. And just remember with vitamin D, the blood level, your blood level will vary by the season and how much sun you're exposed to, and sunblock will not allow you to absorb vitamin D. If you do have low bone mineral density, your vitamin D and calcium are fine. You should consider pharmacology, meaning treatment with medication. The treatment for low bone mineral density, the first-line treatment, is a class of drugs called bisphosphonates. And you might recognize some of the brand names there in the parentheses. The other one, the drugs that I've listed are oral as well as IV. Again, an endocrinologist is the primary doctor who might help you decide which one is best for you. Some people prefer to take things orally rather than IVs, but with oral agents, often you have to be upright for 30 minutes to reduce the risk of feeling burning in your esophagus. How does the bisphosphonates work? So this is a very effective treatment for restoring bone mineral density. The way it works is it acts on those osteoclasts, those cells that eat up bone. It reduces the activity of the osteoclasts so there's less bone resorption. Unfortunately, there are side effects in a small percentage of people. With the first infusion, they may have flu-like symptoms. You can develop low calcium, and a very rare percentage might have a destruction of the muscles of the jaw. It's called osteonecrosis. As far as the duration of how long should you be on a bisphosphonate? Well, after 5 years, it's really not clear what the benefit is, and your doctor might say, you know, I want you to have a drug holiday for a short period of time. Not everyone who has low bone mineral density is responsive to bisphosphonates, or they might not be able to tolerate them for whatever reason, GI, flu-like symptoms. And there are some other agents. Another anti-resorptive agent, meaning it works on that osteoclast, is something called denosumab. And this is an antibody that binds to a regulator of the osteoclast. It binds to something called rankle. The rankle is necessary for the osteoclast to do its activity, to eat away. So if you bind the rankle, it won't allow the osteoclast to do its work, and you have less bone resorption. And this is given sub-Q every 6 months. Another class of drugs that are used for treatment of osteoporosis are ones that stimulate bone formation, which I mentioned briefly. Hormones have been synthesized. Parathyroid hormone and calcitonin can be given. And it's not the first-line therapy. They have side effects as well, but it is an alternative if you can't tolerate or you're not responding to the bisphosphonates. So what do we know about bone health and other neuromuscular conditions? Well, the data is very limited, and what we do know comes from the pediatric neuromuscular literature, especially from children with conditions such as spinal muscular atrophy and Duchenne muscular dystrophy. These children have lower bone density and increased fractures compared to their able-bodied peers. Now let's talk a little bit about Duchenne muscular dystrophy. This is another inherited condition where it affects boys, and they usually stop walking by about the teen years. So they have risk factors for fracture based on their progressive muscle weakness and loss of ambulation, limited weight bearing. Most of them do have vitamin D deficiency, and most are on corticosteroids, which is associated with decreased bone formation and increased resorption. An interesting study on bone health in boys with Duchenne looked at vitamin D. So this was an Italian study looking at 33 boys, and at baseline, they looked at their bone mineral density and found it was low in most. They also looked at their bone biomarkers and found that resorption biomarkers were increased. The intervention given was vitamin D along with calcium for about 2 years. And at the end of the study, they again looked at their bone mineral density and their biomarkers, and there was improvement. They found that the bone markers for resorption actually decreased, and their bone mineral density improved in 2/3 of the boys. So the conclusion from this study was that vitamin D is a very effective first-line approach in controlling bone turnover and increasing bone mineral density in boys with Duchenne. The question is, can we translate this to other muscular dystrophies? So there are guidelines for bone health in Duchenne muscular dystrophy, and it's there are some similarities with FSH. On the left-hand side, bone health issues include decreased mobility, muscle weakness. Suggested tests would include all the biomarkers, scanning with DEXA, interventions, vitamin D, calcium, and bisphosphonates. So getting back to FSHD, do individuals with FSHD have an increased risk of fractures? Well, as you know, as strength decreases and the risk of fall increases, and as muscle mass decreases, bone mineral density decreases. So these factors together, falling and decreased bone mineral density, would make the risk of fracture fairly high. But we don't really have that data yet. So how can we assess for fracture risk in the FSHD community? At present, no guidelines exist for screening bone health. And to address this need for the FSHD community, the FSHD Bone Health Study was conceived and designed through FSHD Global with the principal investigators, Dr. Wagner here in the US, and in Australia, Dr. Alistair Corbett. So if you would just Google FSHD Global, it's another Australian organization that's dedicated to finding a cure for FSH. If you wanted to learn more about any study or our study, you could go into clinicaltrials.gov, and this is a service from the NIH. And in the search box, I put FSHD, and what came up were, at least at the top, you can see our bone health in FSHD is on the top there. If you would click on that, you would see where the sites are, the inclusion/exclusion criteria. You would see Ms. Jenny Bebot's name on there, her contacts, and how to be part of the study. So if you would be interested in any study, this would be a great site for you to look at, clinicaltrials.gov. When you do join a study, because you're a volunteer and you're a human subject, you need to get your permission. You need to get informed consent. And this is our cover sheet from our informed consent, which is really protecting your personal health information and your privacy. So our study is a cross-sectional study. It's a single visit. We look at the neurological history, allele size, we do an exam, and similar to your regular clinic visit, we look at muscle strength and also time to function by the physical therapist. How long it takes you to get up out of a chair, walk 10 meters, how far can you walk in 6 minutes. In addition, we do imaging, looking at your bone mineral density, your lean body mass with DEXA, and we check your blood work for serum biomarkers. Our goal is to get 50 patients at this site, and actually as of this week we have 44 patients enrolled. We're going to get 50 in Australia for a total of 100, so we're getting very close. These are just some of the biomarkers. We're looking at bone resorption, formation, and other markers of bone health, including hormones, calcium, vitamin D, and allele size. Just mention a little bit about the genetics of FSHD. So in this picture, I don't have a pointer. On the very top is a chromosome. It's chromosome 4, and at the end where it says 35, that area, 4q35, there is something called a D4Z4 array. It's just below, and that array is a sequence of repeating DNA units. And we can measure those units in kilobases, kbs. We're very interested in this D4Z4 region because if you have more than 42 kilobases, you do not have FSHD. If you have less than 38 kbs, you are genetically confirmed you have FSHD. But what does this actually mean? So we believe that FSHD is caused by a shortening or deletion of this D4Z4 region on the chromosome 4. Why is that? This region of D4Z4 contains something called DUX4, and this factor controls expression of other genes. And normally, this DUX4 is turned off, not expressed, not active. However, when there's a shortening of this allele, shortening or deletion in the D4Z4 region, the DUX score is expressed. And when it's expressed, it's toxic. And we believe the expression of this DUX score is what's causing the skeletal muscle pathology in FSHD. So we're interested in the allele size of the study to see what the correlation is with a lot of features of our study. Just go over some of our aims. We're looking at bone mineral density, lean body mass. Are they reducing in people with FSH? Do individuals with FSH have more fractures compared to their age-matched controls? How does bone mineral density correlate with muscle strength and time testing? Do fractures or bone mineral density correlate with the allele size that I've just reviewed? And how do fractures relate to bone turnover markers? Our ultimate goal of the study is really to provide evidence for establishing medical guidelines for screening, treatment, and maintaining bone health in FSHD to promote the highest standard of care and quality of life for the FSHD community. Until we have those guidelines in place, I do recommend a few steps for prevention of osteoporosis and fractures. First of all, a balanced diet, which would be rich in calcium and vitamin D. Weight-bearing exercises. Doesn't mean you have to go to the gym every day, but walking, dancing, even shopping, anything that keeps you moving. Now, for those of you who are not able to walk, I'm just going to put a plug in. In San Diego, we have a very large wheelchair dance organization. Anything that keeps you moving, I would highly recommend. Healthy lifestyle, no smoking or excessive alcohol intake. For those at risk, bone density testing should be done with DEXA. And if your bone mineral density is low, I would recommend pharmacologic treatment. It really does make a difference. Great resource for understanding more about prevention for osteoporosis and fractures is the National Osteoporosis Foundation. A lot of great information. And with that, I'd like to thank you all for coming on this rainy day. I'd especially like to thank patients and their families for their generosity of time. I've learned so much from each patient. I'd also like to thank members of the Wagner Lab, as well as the entire team of the genetic muscle disorders. So, if you have any questions, I'd be happy to take them. Yes.
We mentioned the treatments such as the Fosamax, etc., and that the more than 5 years there's no research to show the benefits. So here, as our son is 38 years old, and you're looking at long term, what happens in this period of time that you're taking it? I myself took Fosamax, I'm now off of it, but will it continue beyond once you stop for some period of time? Because we've had him, he's talked to an endocrinologist and his own doctor, and the hesitancy in putting him on these types of drugs because he's so young. Can you talk a little bit about that?
I'll be honest, I have limited experience, but what I've seen from the endocrinologist here, if someone is going off of the bisphosphonates, they follow their bone density. And if their bone density starts to drop again, they might consider a different agent. I remember a young woman that we're following that is going to start one of the hormones. She's going to start PTH. But again, every case is different, and I think the endocrinologist would be the best person to discuss that with. I don't know.
I guess my only other comment is that you suggested that there's concern about age, and we treat children with bisphosphonates. Not all of these drugs have been proven to be safe in children. So, for instance, reclass is not used in small children. So it's not that it's definitely not helpful, but most of these drugs are used in children, maybe as a child, but anyway, because of its age, there's no concern.
So taking it for long periods of time.
It's good to take drug holidays from it.
Okay.
So you don't put somebody on it and leave them on for life. Right. You demonstrate an improvement in bone density. usually take it for the holiday and restart it up again.
How many units of vitamin D and how often would you?
That's a very good question. So there are RDAs, recommended daily allowances. Again, it depends on where you live, for one thing. The recommendations that I've seen are around 600 IUs, but that just seems so low. So my recommendation would be to get your vitamin D level checked. If it's low, then you need to be supplemented. We have a few different regimens. If it's very low, we put a patient on 50,000 units once a week for about 3 months and then recheck it. If it's medium low or just minimally low, probably 2,000 to 5,000 units a day and a recheck in a few months.
Because he is taking 2,000 a day now. He went through the 50,000 some time ago with you, and then we've got him on 2,000 based on what I do, because my oncologist increased mine and said that everything is level.
So a recheck might be helpful.
Now he's on 2,000.
You just changed.
He just changed mine.
You did too.
I did 2. What am I changed to? Oh, I'm up to 5.
Is that dangerous?
I didn't hear what you said.
Is up to 5,000 units dangerous?
I don't believe so. Vitamin D is fat soluble, so if you have too much, you do store it. But I think I would probably ask for another test.
Yeah.
Any other questions?
Is there any benefit to FSH with any of these besides the bone meds?
I'm sorry, is there any benefit?
To any of the,
Oh, okay, that's an interesting question. So there was one study, actually Dr. Wagner did the study with denosumab, but it was just one case report where a woman with FSH received denosumab. She was not walking, and she got up and walked. And then it wore off. She got another dose, and she walked. And I haven't seen any, I did a literature search, and I really couldn't find any other denosumab improvement in FSH. So that was just one case report.
so Catherine, is there anybody that you know that's taken this during this study that you started?
No, none of our FSH patients here are on Prolia. Maybe you could, do you have slide stuff on Prolia? It's an interesting drug, and maybe you could tell them a little bit about it.
So as I was mentioning, it acts on those osteoclasts. That pink Pac-Man at the bottom is an osteoclast. And in order for the osteoclast to work, those little green things are called rankles. This is better. So the little green circles are rankles. They attach to the osteoclast, and that lets it do its work. So those little Ys are antibodies. They bind to those green things, the rankle, and they don't allow the rankle to attach to the osteoclast. So it just decreases the activity of the osteoclast. How it improves weakness, I really don't know.
I think that there are some hypotheses that it may modulate the immune system, that may be helpful to FSH. And I agree with Dr. Grossman that these are just really anecdotal reports, but there certainly has been some interest in this in the community.
So what do we gotta do
Eat healthy.
Probably not the best conversation online.
Yeah. All right, well, thank you very much for coming. And hold on.
No online questions yet, so
Okay.
we'll call it a.
Okay.
People did find this stuff.
Okay, thank you.